So good morning. My name is Sharon Cushing, and I'm a pediatric otolaryngologist and cochlear implant surgeon at the Hospital for Sick Children in Toronto. And one of my clinical and research interests is looking at vestibular function in the pediatric population. And so what we're going to focus on today is exactly how do we evaluate vestibular function in children, and specifically we're going to focus on a relatively new tool that we have, which is called video head impulse testing, and how this can really supplement what we can learn about vestibular function in children. So what we're going to go through today is we're going to look at how do we screen for vestibular imbalance function, and screening is important because in the field there are going to be individuals who are experts at evaluating vestibular function. In addition, there's going to be clinicians who are comfortable screening but not comfortable doing a comprehensive examination. So we're going to look at what we can ask our colleagues to do in order to determine which children should have a more comprehensive evaluation when it comes to vestibular testing. The second part is going to focus on a more comprehensive and still relatively clinically based evaluation of vestibular function. And finally, we're going to put it into the context of the clinical populations in whom it's important to determine what their vestibular function is. So let's start off with what we've termed the easy pediatric vestibular screen. So I have a number of colleagues who are pediatric otologists who run very busy clinics. And when we thought about what is it that we could ask of them to screen for in the clinic when they're seeing children with hearing loss or dizziness or other otologic complaints. And this is what we came up with. So the first aspect of this includes a review of the motor milestones. And what we like to ask families is about head control. And so the range of normal for the development of head control is somewhere between 6 weeks and 3 months of age. Anything that falls outside of this will be considered grossly abnormal. The next thing we ask about is when the child sat unsupported. And again, a typical range would be between 6 and 9 months. And finally, and probably the most relevant, is the onset of walking, which should be somewhere between 12 and 15 months. One of the things that you see in children with bilateral vestibular loss is a delay in the age of walking to about 18 to 24 months. Now, in complex clinical settings, you'll see children who walk late for all different kinds of reasons, neurologic reasons, central reasons, and certainly if walking is delayed beyond 2 years, then the likelihood of a central or a neurologic component to this is much more likely, whereas children with pure bilateral vestibular loss and nothing else will walk sometime between 18 and 24 months. Now, one of the things you'll notice is that when you ask families, especially those with multiple children, about the motor milestones, they often get confused because they can't remember who walked when and who was on time and who was a little bit later. But one of the things that is very obvious is that when a family has a child with bilateral vestibular impairment, they absolutely remember when it was that these children hit all of these milestones. And the minute you ask any one of these questions, it'll really open the floodgates to a whole host of information. And you might wonder, why don't families volunteer this information when they come in to see their otolaryngologist for a complaint of hearing loss, for example? And the reason is that they don't make the connection that there are really two parts to the inner ear, the hearing part and the vestibular or balance part. And so unless we help them make that connection, oftentimes relevant components of the history will be left out. The next thing I ask my colleagues to do is to have the child stand on one foot. And so we'll look at what is the normal spectrum for this. And what you can see is that a child who is 2.5 years of age, 30 months, will be able to achieve a 1-foot standing posture for a brief amount of time. So transiently up and transiently down. By the time a child is 5 years of age, they can do this easily for 10 seconds. And what you'll notice when you look at a number of children with peripheral vestibular impairment is that even a 15-year-old with bilateral vestibular loss cannot do what a 5-year-old can achieve. And so this allows for a quick screen that's easily done in the clinic to identify that child who should have further evaluation. Now, if we only did those two things, we looked for motor milestones on history and we had the child do 1-foot standing, we would be able to collect a certain number of children who do have peripheral vestibular impairment. But if I had thrust test, and this is very relevant because it's a test of the peripheral end organ, the lateral canal. It's a high-frequency test, so a real-life test to a real-life stimulus. And what we're looking for is shown in this next video. So this is a little guy. He's 2 years old, and he has meningitis. And what you can see is that we're going to put him on Dad's lap, and we're going to do a head thrust from side to side. And you can see he actually doesn't mind it so much. We're going to talk a little bit about the target and the placement of the target in a little while, but let's focus on his eye movements. So what you can see, I want you to pay attention to how his gaze shifts. There we go, a big, large saccade back to the center, in particular when going to the left. And so you can see that you're able to achieve these results even in a small child. Now, those are sort of the three things that I ask in terms of a screening test. Some of my colleagues do a couple of them. Some of them will also include the head thrust test. But I think that's really a baseline that's doable for most clinicians. What we're going to move on to from here is how do we do a more comprehensive evaluation of vestibular and balance function in children. So when we think about vestibular and organ function in children, we really have to think of development, because certainly in adults you're dealing with a system that is already mature, already fully developed, whereas in children we may be catching them at a time of development, and we have to know what's reasonable for a given age. The good thing about the vestibular system in children is that it develops very early, and even by the time children are born, they're already starting to myelinate their vestibular nerve. And so from a sensory system, it is one of the earliest systems to mature, which means that we can accurately test function at very, very young ages. Now, when we think about how responsive is the vestibular system in young children that we may be seeing in clinic, well, what we know is that you can obtain a VOR response at 2 months of age. By 6 months of age, children will be able to suppress their VOR, and it's at that age that you can begin to achieve reliable caloric responses. That being said, doing calorics in a 6-month-old is not an easy thing, and there are very few people in the world who are able to achieve that type of testing. When we think about maturation of the VOR response, it can happen later on, so starting at 2 years of age, and certainly the optokinetic system in smooth pursuit is mature by the teenage years. Now, a few points to make is that infants, as I mentioned, less than 6 months cannot suppress their VOR. And we can use this to our advantage when we're testing these very young babies in the clinic, because if you rotate a child and you're looking for the VOR response, you typically have to put them in dark, but not babies under 6 months of age. You're able to rotate them as they're not able to visually fixate and suppress their VOR. So this can give us insight into how the labyrinth is working in very, very young children. The other thing to note is that an absence of a VOR by 10 months of age is considered very, very abnormal, and this child should certainly have an additional workup that includes likely some imaging and a neurology referral. So let's move on. So when we think about our neuro-otologic physical exam, there's an exhaustive list of different types of tests that we can do, and in children, what we often have to do is focus on what's most important to us. So this is a complete list that you can see, and I've divided in terms of static testing, dynamic testing, and vestibulospinal testing. In this next slide, I've highlighted those tests which I find to be the most relevant. Obviously, if a child is going to allow us, we're going to go through the entire list, but that's often not the case, and anyone who deals with children realizes that you have to prioritize and get what you need the most first. What I've highlighted in red are those tests that I prioritize, if at all possible, and in purple I've highlighted those tests that can require additional equipment, and we'll show some videos demonstrating the type of equipment that can be used in order to get accurate assessment in those realms. when residents come to clinic with me, they often want to have an outline of how do I do the dizzy exam and in what order do I go through things. And so I've created this list for them that is my top to bottom list of the pediatric physical exam, and it's in order in which I complete the exam. There are many ways to go about this, but for our residents, they find this type of listing very useful in terms of organizing themselves both in the clinic and when it comes to exam purposes. Obviously, any physical exam is going to be accompanied by ancillary tests that include a complete audiometric assessment, and in this I also will include reflexes, which is not always part of our standard pediatric audiometric assessment, and we'll talk more also about what we're able to achieve with respect to formal vestibular end organ testing. So let's go back to the head thrust. Certainly this is my favorite of the tests, and I think the one that if I was only able to do a single test, this would be the one that I would do. And it's called all different kinds of things. In Canada, we tend to call it the Helmagi head thrust test, and more recently it's the term head impulse testing has been associated with our ability to do this by video as well. Here we have another example of a child doing the head impulse test. This is a child with bilateral cochlear implants. Now, in children, sometimes you have to compromise in terms of your ability to do the testing. And most people looking at this video who know a lot about head impulse testing would say, gosh, that target is so close. And it becomes very difficult in children to put the target so far away that they lose interest. And so at times you need to manipulate the test and compromise on the way that you would love to do it in order to get the result that you need. This is where video head impulse testing comes in. You can see that the two videos that I've shown of head thrust testing were actually recorded. And oftentimes I think many clinicians who look after children will feel as though they spend so much time and energy focusing on getting the test done that it also becomes difficult to interpret the test as they're doing it. And oftentimes, up until we had the availability of video head impulse testing, we would record the head impulse test with a video camera in order to be able to look at it again, to play it back, to play it in slow motion, because as I mentioned, you spend so much time and effort at entertaining the child and getting the test done that sometimes that makes it difficult also to make the assessment as the clinician. An even better way of doing that than using the video camera has been the advent of video head impulse goggles. Now, what these are really meant to do in my mind and how I use them in the clinic is to supplement my physical exam. And in children, as I mentioned, this is particularly important because not only do they require a lot of energy to entertain, they also move their eyes very quickly, and they're also very good at programming corrective saccades in a very accurate way that can certainly fool the clinician. And one of the beauties of vHIT goggles is that they allow us to detect both overt as well as, more importantly, sometimes covert saccades, which I think in general children are very, very good at producing. It allows us to document normality and abnormality, and they can be used and are portable in the clinic setting. And so, you know, I wheel these from room to room. I bring them to the ward with me, and they really do help supplement my clinical and physical exam. Here we have a little picture, and I'll show you a little video of this, this young lady who has bilateral vestibular impairment. And again, it takes a parent, it takes some distraction, but this picture is meant to show you that we can get these adult-type goggles to fit on small, the small heads of an 18-month-old. So let's move on. The other things that I like to test in the clinic, and these are truly in order of preference, are per-rotatory and post-rotatory nystagmus. This is a fun test for children. There's a few tricks that you have in order to get them to participate. And what I'm going to do is I'm just going to show you a little video of how we do it in the clinic. When I use this test, I am using it qualitatively. So I'm not quantifying the characteristics of the nystagmus, what I'm doing is I'm looking to see, do they have per-rotatory and post-rotatory nystagmus. So you can see that we're rotating this young boy in a clockwise fashion, and the fast phase of his nystagmus is towards the side of rotation, the direction of rotation, and he's having a good time. You know, my rate of turning is not equal. There we go, we've stopped him, and you can see that now the fast phase is beating towards or against the direction of rotation. And we're going to wait and let this suppress. I'll ask him, do you still feel like you're moving? And the answer is often yes, until you see a suppression of the eye movements. And so most kids will enjoy this kind of testing. It does need to be done in the dark, with the exception of babies under 6 months, and that can be a challenging thing for children to do. So most children don't like the word dark and don't like thinking about being in the dark, and so initially when I started to do this type of testing, I would make the mistake of saying, okay, it's going to be dark now, and they would get very anxious. And so now I avoid that type of use. We talk about night vision goggles and a spy test or a princess test, depending on what it is we're doing, in order to be able to get the goggles on. And you really have to communicate with children throughout this type of testing so that they know they're okay. You can also put them on the parent's lap, just as you would in a rotary chair, and this allows you to test in clinic without the need for a rotary chair easily whether or not there's the presence or absence of per-rotatory and post-rotatory nystagmus. Then subsequently what we look for is head shake nystagmus, and I highlight this one again because it does require some additional equipment. Again, I use a VNG goggle or a video Fresnel goggle. You could also use Fresnel or Fresnel lenses as well. And you can see that we've tipped the head down 30 degrees and we're shaking it side to side. I usually try and make this a little bit of a game, so we either sing a song or we practice saying no, that we're not going to clean our rooms, no, 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 we're not going to eat our vegetables, and the kids really do get into it. We want to charge those labyrinths for a period of time, and then what we're going to do is we're going to look to see whether or not there's any beats of nystagmus once we have finished the head shake testing. Again, you can do this qualitatively or quantitatively depending on the system you have and depending on the tools that you have in the clinic. This next video is going to show you a test where it's positive. I'll just point out that the left and right eye are on opposite sides, and so what we're seeing here is the fast phase of the nystagmus towards the left. And so after head shaking, what you'll note is that the fast phase of the nystagmus will point towards the side of the intact labyrinth. And so again, you can see that this is very subtle nystagmus. Certainly this would be suppressed if the test was not done in the dark with the removal of fixation. And this is one of the areas where, again, video playback, where you can go back and you can look now that you don't have to entertain the child. You can actually do a very good clinical assessment by reviewing the images afterwards. So let's move on to looking at some of the formal testing that we can do for the vestibular end organs. And what I like to do is to really think about what is the physiologic entity or the anatomic entity that I'm testing, and what tests can I use in order to look at that function. And so what we're going to focus on are tests of lateral canal function and tests of saccular function. And so how can we access the function of the lateral canal? Well, what's been around the longest is caloric testing, and this will test low frequency lateral canal function. It can be achieved in children, and there are individuals in the world who are able to do so even down to 6 months of age. Our success rate has been good in children about 4 years and older, but it really does depend on the child and the testing scenario. We can use rotary chair testing, which has the advantage, depending on your chair, of looking at low and high frequency rotation. We're fortunate here in Toronto in that we have a chair that can rotate all the way up to 15 hertz with the use of a scleral coil, but most commercially available chairs will still rotate under 1 hertz. And finally, this newer and exciting tool in video head impulse testing, which we've already talked about. So the video head impulse testing really does span the clinic all the way to the end organ testing lab, and so it really can be used in either or both of these scenarios. And finally, when we're looking at saccular function, we are going to do so by doing a cervical vestibular evoked myogenic potential. Now, as time is going on, we're becoming better able to probe the other parts of the vestibular apparatus, including the other canals, as well as the utricle. And hopefully, in the not-so-distant future, with the use of new technologies like the video head impulse test goggles, we'll be able to do this easily in the clinical setting. So when we think about lateral canal function, as I mentioned, we want to really test high-frequency lateral canal function, and that's what the vHIT allows us to do. It allows us to assess laterality, and it really is an alternative to rotary testing. In an ideal world, you would have access to all of the technologies, and the child would cooperate through all of the technologies, but the reality is that that's not always going to happen, and so the vHIT testing is really an easy way to probe lateral canal function in the clinic. It doesn't require a huge amount of space or resource in order to be able to easily and accurately test lateral canal function. Here's a little video of our little girl playing with our the toy that we like. You can see that, you know, once we have the goggles on her, the fit is very good, even though she's quite a small child, and she's not really bothered by them. It's oftentimes a little bit of a crying match in terms of getting them on, but once they're on, the child can then be easily distracted, and the testing can commence. So when we think about pediatrics, there's the ideal setting versus what's reality, and I think any of those of us who routinely test children know that some of the things, as I mentioned, that you would love to have happen are really going to go out the door, and you really have to get creative. When we think about how to set ourselves up to succeed when we evaluate vestibular function in children, I think you really have to allow yourself adequate time, because a rushed approach is not going to work. Your ability to set up the parents as to what to expect will help a child come into the clinic ready for testing. You really do have to prioritize, because you never know how far you're going to get, and you may only get 1 or 2 tests before the child has a meltdown, and so really you want to focus on what's most important, also balancing what is most aversive in order to try and maximize what you're able to get in a single session. I think you have to realize that it may require several visits, so depending on the day, the time of the nap, the mood the child woke up in the morning, what the other routine was for the day, it may require several visits, and simply having the same child back on a different day can make a world of difference between achieving results and not getting any useful information. You have to be ready to play and to have lots of accessories for play, and oftentimes an additional tester whose sole focus is to play with the child so that you can get done what you need to do. You do at times have to settle for less than perfect, and I think as clinicians we at times find this difficult because we want the perfect test that allows us to tell families what we're seeing with certainty, but really at times we have to settle for less than perfect technique and less than perfect results, because I think at times if we wait for it to be perfect, we're never going to test children. This is one of my favorite quotes by Rapin, who has extensive experience testing children. And what she said is that vestibular testing in children rarely fulfills all of the conditions for an ideal vestibular study. And I think we really have to keep that in mind in order to get what it is we need out of this testing. So truly the bottom line is that it's not going to be easy. It'll be a challenge, but a fun one. The results won't be perfect. We're going to have to settle for some lost time. You're going to test what you need most first, and kids move their eyes a lot. I've spoken about this already. They like to look all over the place, so you're going to have to focus and refocus them. And certainly when at first you don't succeed, you just need to continue to try again, and eventually it will come. And what a joy it is when you are able to get useful information out of a child. So let's put what we've talked about so far into some context, because now that we have the tools that allow us to look and probe vestibular function in children, when do we use them? And so really when I think about this, I think about two populations. So there's the children who come in to the clinic with vestibular and related disorders. So these are the dizzy children who get referred with that being the primary complaint. The other large group of children that I see are children with cochlear vestibular loss. And so these are children who come in through your hearing loss clinics or who truly come in for the sole purpose of hearing rehabilitation, where it's very important that we look at the vestibular function in that ear as well. So why do we care? Some people would say, well, even a child with bilateral vestibular loss is still going to walk into the clinic. I really don't see these children in my population. And the truth is, my answer to that question is that it's partly because you really have to look hard for them, because children do a remarkable job of compensating for vestibular impairment to a certain degree. So they do plateau, and we'll talk about that plateau a little later on in the talk. But these children are out there, and the more you look for them and develop the capacity to assess them, the more of them you'll see. We do know something about the prevalence of these children, and we're going to talk about that in the next couple of slides. There are things that we can do to help them, and some of them are as simple as providing families with a diagnosis. And so what I mean by this is the relief that we see on the face of a parent when you identify their child with a peripheral vestibular loss as an explanation for what they've been seeing since their child was born: poor head control, inability to sit at a typical time, difficulty with walking, clumsiness on the playground. It really validates what they know is wrong with their child, even if we can't go that step beyond in terms of helping them. There are things that we can do to help them by way of therapy, physical therapy, vestibular therapy, but really even just making that diagnosis is a huge help for families. The last thing, and this is where I really get excited about research, is that children are amazing. And I think that looking at how they compensate for vestibular dysfunction, that the type of dysfunction that if we acquired as adults would render us incapable of being mobile, they really can teach us something. So if we look hard enough as to how they're able to overcome some of the difficulties associated with bilateral vestibular loss, we're really going to learn a lot that's going to serve us well, both in the pediatric setting and in the setting of our aging population. So when we think about what the implications of a peripheral vestibular disorder is on a child, we think about motor function, but really there's good literature to suggest that the impact of such dysfunction extends well beyond just motor function and performance on the playground. Ultimately, these types of disorders impact on a child's educability, sociability, and employability, because a peripheral vestibular loss has impact on all of these different realms in terms of attention, reading and writing difficulties because of oscillopsia, spatial disorientation in that they're unable to sort of accurately tell where their body is in space. That can cause issues with personal space and social difficulties, and they really have a challenge in terms of abnormal pathway interpretation, and this can even lead to memory issues. And so I think we're only beginning to understand the far-reaching difficulties that a child with peripheral vestibular dysfunction has and the impact it has on what's important in life, which is in this center circle. So one of the interesting things about children with peripheral vestibular loss is at times a lot of them really don't complain, and this was really highlighted to me by looking at this study where they had 62 children with a basilar skull fracture, and in this cohort 34% of them had a sensory neural hearing loss. And so what that tells you is that there was a significant concussive or fracture injury to the cochlear vestibular apparatus. But even in light of that, few of them had vestibular complaints. And so this may relate to a child's ability to articulate what they're feeling. It may relate to the fact that children don't really mind being dizzy in the same way adults do. But really, I think it highlights to us that we really have to look hard for the impact of these types of disorders. Now, when children present with an impairment in vestibular function, it can look very different than an adult who is presenting with a similar lesion. We have to look for delayed motor function because we have to remember that children are on a developmental trajectory, and we have to look for loss of postural control. And in children, that can be very accepted as a child being clumsy or uncoordinated. Vertigo can appear as fear or panic, where they cling to their mom or dad because the room is rotating, but with an inability to express what they're feeling. They may have periodic nausea and vomiting, not so unusual in a young child. They may be unable to achieve some of the goals of childhood, like riding a bicycle. And so their presentation may not be as straightforward, and you really need to have your eyes out for it as a clinician. How they describe the sensation also can be very different. You know, children will use the term dizzy. They won't use the term vertigo unless they've heard it by a parent, but they'll often say the room is spinning or the house is shaking. I'm on a roller coaster or a merry-go-round, or describe floating. So they use these very descriptive ways in order to describe to the people around them, if they have the language capacity, what they are feeling. Children who have significant peripheral impairment or episodic vertigo may also come with labels, and I think we have to be mindful that at times these are mislabeled. So they may come with a history of seizure when what they're truly having is a vertiginous attack with nystagmus. They may be labeled as having tics or strabismus or developmental delay because of their motor impairment. And so children may come to us through all different avenues, and we have to again be mindful of, you know, what the vestibular end organ is doing and how much is it contributing to the presentation that I see. So when we evaluate, as we've talked about already, vestibular function in children, they really are not just little adults, and that's what the joy of it is finding a way to engage the child to get the information that we need to make a diagnosis. So what we're going to finish talking about are two groups of children. The first is going to be those children in the first group. These are children who come in and say, I'm dizzy, I have vertigo, and we'll talk just briefly about the types of disorders that fit into this realm. So when we think of how common this is a study by Dr. Russell, who sent out a questionnaire to school-aged children, and it was a very vague commentary about, you know, have you had an attack of dizziness in the last year? So again, could mean a number of things, not all of which represent peripheral vestibular sensation. And so 15% had experienced one episode of dizziness in the last year, and in under half, that dizziness was unexplained by infection, trauma, or meningitis. So I think it tells us that these symptoms are very common, and that we're going to have to be astute clinicians and have appropriate tools in order to figure out which of these dizzy children indeed has an issue with their peripheral vestibular function. So the next couple of slides really goes through a differential diagnosis of a child who presents with vertigo without hearing loss, because we'll talk about those children with hearing loss in the next section. When we think to think about, to teach, and so this first category are those children with vertiginous symptoms that are acute. So in that category, I will put in benign paroxysmal positional vertigo, which is exceedingly uncommon in children. And in my clinical experience, I have only ever seen this following a significant concussive episode. What's remarkable to me is how long children will be symptomatic with this before somebody recognizes that it's vertigo, that it is BPPV. And certainly I had a child recently who had been vertiginous for a period of over 10 months following a concussion, who indeed had BPPV that responded to repositioning. What will be very common in children is migraine variants, and we'll talk a little more about that. There are some vasogenic or cardiogenic causes, such as postural orthostatic tachycardia syndrome, or POTS. There's epileptic vertigo, and certainly this is one of the things that we need to rule out, is that the child is not having seizures, in particular temporal lobe seizures. And then there is vestibular neuronitis, which can be tricky in children, partly because they compensate so quickly. When you see an adult with vestibular neuronitis, again, they are incapacitated for many days, if not weeks, whereas a child, the recovery period will be much shorter, and you really have to see them within the first day or two in order to really capture the symptoms that allow you, and signs that allow you to make an accurate diagnosis. Let's move on now to those children with vertigo that, again, not associated with hearing loss, but is more chronic dizziness. And certainly the children that we see in this category may have vertigo related to their Chiari malformations. So oftentimes MRI is a very important step in the workup of vertigo in children. They can have early MS or ocular abnormalities, and so we work closely with our ophthalmologists. They can be post-concussive, so labyrinthine concussion, which I often think of as a double whammy, in that these children will often have a cerebral concussion in addition to a labyrinthine concussion, and so both the labyrinth is affected as well as their central abilities to compensate for that labyrinthine concussion. There are some unusual familial types of ataxia, and these are exceedingly uncommon. And then finally, vertebrobasilar insufficiency, which is exceedingly uncommon in children. What I have in the next few slides is a potpourri of studies that have looked at their cohort of children presenting to clinic with vertiginous symptoms. And what I've done in the next few slides is really to highlight the top 3 or the top few diagnoses to really show you what is the most common, and you'll see a recurring theme. So certainly migraine-associated vertigo, BPVC, which is benign paroxysmal vertigo of childhood, and this is felt to be a migraine variant, as well as vertigo associated with trauma, followed by a laundry list of diagnoses. This is another study by Rena, and again we see benign paroxysmal vertigo of childhood, so the migraine variant, migraine-associated vertigo, and vestibular neuronitis. So again, migraine-related disease is exceedingly common in children. This is by Dr. Ravid, and again, similar themes. So I show you all of these to demonstrate that, again, the top diagnoses are very common between case series. This is by Dr. McCaslin. So again, they had a much smaller definition, and they looked across a number of different studies, which is why I like this paper in particular. And again, migraine, benign paroxysmal vertigo of childhood, otitis media related, viral infection, and trauma are again the most common diagnoses. We're going to take a little bit closer look at this last cohort, and this is Rob O'Reilly's cohort down in Nemours, where they do some beautiful testing. And what we see when we look at their top 3 diagnoses is that peripheral vestibulopathy is the most common. We're going to look at a breakdown of that. Migraine and benign recurrent vertigo of childhood is the second most common diagnosis, so consistent with the other series. And then motor and developmental delay. And you'll see these children creep into your clinic in a number of different ways because they have disequilibrium, some of which may be associated with peripheral vestibular dysfunction and some not. So where testing becomes very important. So let's look more specifically at this group of children with peripheral vestibulopathy. So when we look at the diagnoses, the most common is inner ear malformations. And so these are going to be children who, for the most part, have an associated hearing loss or an anomaly that affects both the cochlea and the vestibular end organs. Second most common, again, is in a similar vein, those children with sensorineural hearing loss. And we'll talk a little bit more about this in the next section about those etiologies of hearing loss that are very commonly associated with peripheral vestibular dysfunction. And then finally, benign paroxysmal peripheral vertigo. And again, certainly in Rob's cohort, these children are almost exclusively post-concussion. So the final thing that Dr. O'Reilly looked at was the distribution of the individual diagnoses in children with migraine disease, which again made up roughly a quarter of the whole population that they saw. The majority had migraine equivalent. A portion had true migraine that met all criteria. A similar proportion had benign recurrent vertigo of childhood. So this is the same as benign paroxysmal vertigo of childhood. They're both the same and they're all migraine variants. And then paroxysmal torticollis, which is also felt to be a migraine variant. So let's move on now to the final part that we're going to talk about, and that's the children who don't know they are dizzy. So these are the ones, these are the children where they have a vestibular and a balance disorder that's associated with their deafness. So when we think about the building blocks of both the cochlea and the vestibular end organs, they're essentially the same. They're the hair cells, and what activates them is different. So in the cochlea, they're activated by sound, which leads to a change in the movement of fluid, whereas those hair cells in the peripheral vestibular end organs are activated by movement and changes in position of the head. But essentially the building blocks are the same. And so it makes us realize that if there is an etiology or an insult that affects the hearing aspect of the inner ear, then certainly it's very possible that that bleeds over and affects the vestibular aspect of the inner ear. And so again, because we love classification as human, what I've done is in the next two slides I have looked at a differential diagnosis of vertigo in children with hearing loss that's both acute in onset. So again, viral neuronitis, labyrinthitis can be associated with hearing loss, otitis media, concussion. All of these can be associated with an acute onset of hearing loss as well. Then there's the children with subacute or chronic onset. So these are children with ototoxicity, Meniere's disease. Again, otitis media fits into this. So this is just a way of classifying it. It's by no means a exhaustive or complete list, but just a way of getting your head around it as you're thinking about these. One of the things that we have done in Toronto that we've been really interested in is classifying the vestibular function in our population of children with profound deafness. And in particular, these are children who, for the most part, go on to receive cochlear implants. So severe to profound deafness, either in a unilateral or a bilateral setting. And up until now, we've tested just over 200 children, and this cohort is of a relatively representative etiology of what we see in our overarching implant population. And we've done a whole host of things in terms of end organ testing. So the majority of these children would have gotten caloric testing. Early on, they were receiving rotational chair testing, and we've essentially exclusively replaced that with video head and pulse testing. And they would have also received them in addition to a balance assessment, which we'll talk about a little later in the talk. When we look at the prevalence of dysfunction, what we see is that roughly 35 to 40% of children in our implant population have significant impairment of their vestibular end organs. And the groups that I've highlighted in yellow are those that are much more likely to be associated with this dysfunction. And when we talk about this 35 to 40%, I'm not talking about a mild reduction in caloric function on one side. These are children with bilateral areflexia, severe dysfunction of their end organs, many of which cover both the saccule and the lateral canal. And so really that prevalence tells us that we really need to be looking for vestibular function in all our children who present with hearing loss. Now, children don't care what their lateral canal is doing or what their saccule is doing. What they care about is being functional on the playground. They want to play soccer, they want to play hopscotch, they want to be as good as their best friend at these tasks. And so we've always felt that it's really important to not only measure end organ function, but also the functional correlate of that balance. And so one of the ways that we've done that is by using this test called the Brunick-Oseretsky test of motor proficiency. And it's not so important what it includes other than that it's an easy test that we administer in the clinic. And it comes with beautiful age-referenced normative data that allows us for accurate comparison regardless of developmental stage and age. And this is what we see with our implant population. So in red, we have the normative data, and in blue, we have our overall population of children with cochlear implants. And what you can see is that there is a significant difference between the two populations, with the children with hearing loss and cochlear implants having significantly poor balance. Now, these are all comers. This is everybody in the population, and so some of them may have intact vestibular function, and some of them may have absent vestibular function. So we wanted to try and break it down to get a better sense of who was really at risk. And so we broke it down by etiology, and what we see here is that this is the individual data for the children contained in that blue bar. This is everybody, and you can see there is a huge variability here. From expert performers, these are our Olympic gymnasts, to children who are having a really, really hard time staying upright. And so when we break it down with respect to etiology, and again, if you'll remember from the first slide, this group in yellow are those that are the hardest hit when it comes to impairment of their vestibular end organ function. What we can see is that the mean does get reflected by etiology. And so certainly children with Usher's syndrome are way down here. They have terrible balance. Children with abnormal cochlea, on average, have significantly poor balance, but there's a huge range. And even children with etiologies that we don't feel should be associated with peripheral vestibular dysfunction, again, we see a large range in this population. So what this told us is that while etiology is predictive on a population or a group level, for the individual, it may not necessarily be predictive, and this really does underline not only the need to determine etiology, but also the need to test children individually for their peripheral vestibular function when they come in with a hearing loss. So in conclusion, if I think about the take-home messages that I'd like to have resonate today, is that vestibular and balance function should be evaluated in all children with hearing loss. When we think about the other things that we test in children with hearing loss, that sometimes we'll talk about testing cardiac function with an EKG, looking for very uncommon abnormalities, or we'll test renal function for that small population of children who will have associated kidney dysfunction. Whereas the most common associated abnormality with hearing loss is vestibular impairment, and I would hazard to say that most clinicians don't even look for it. Now, I hope today that we've underlined that there are some screening tools that you can use in order to identify those children who are at risk of having vestibular dysfunction, and that these screening tools are relatively straightforward. A history of motor milestones, standing on one foot, and possibly a head thrust test. Now, in summary, as I just mentioned, screening for vestibular dysfunction is feasible. Diagnostics in children can be challenging, they can be intimidating, and I think really we have now available to us the tools, and in particular, one of the focuses of this talk was to look at the utility of vHIT goggles that really help us make objective assessments of vestibular function in children who are hard to test. And I think that as we become more and more comfortable with this technology, our ability to perform these diagnostics in all children is going to be greatly improved. And when we think of those children who are affected by vestibular dysfunction, it truly is a broad differential, but I think we can focus our attention both in terms of those children who come in dizzy versus those with disequilibrium and poor balance associated with hearing loss, and the encouragement to really look for these children, because I think you'll find it very rewarding and you'll learn a lot from them. Thank you very much.